Hello, welcome to the Share Approach Essential Steps of Shared Decision-Making workshop course developed by the Agency for Healthcare Research and Quality. Hi, my name is Dan Matlock. I'm a geriatrician and professor of medicine at the University of Colorado School of Medicine. I'm going to walk through Module 3, Communication Barriers and Solutions. This module addresses the role clear health communication plays in the shared decision-making process. Using effective communication techniques, along with offering your patients accurate evidence-based options, can help you gain trust and build rapport during shared decision-making. The purpose of this module is to describe the role clear health communication plays in the shared decision-making process, and to demonstrate that using effective communication can help you gain trust and build rapport during shared decision-making. At the end of this activity, the participant will be able to, number one, explore common communication challenges that make shared decision-making deceptively difficult. Number two, explain the impact of health literacy on patient understanding. Number three, describe techniques to better communicate health numbers in a way patients can understand. And number four, learn the teach-back method to facilitate understanding and communication. Number five, learn how to make a recommendation in a patient-centered way. And number six, identify strategies to support shared decision-making among diverse patients with an array of social challenges. Let's be honest, seeing patients in clinic can actually be quite difficult, and communication is really hard. This slide shows data about common communication challenges. For example, 9 out of 100 patients will have limited English proficiency, and sometimes it is difficult to find qualified interpreters. 21 out of 100 have low health literacy. 2 out of 100 have visual impairment. 3 out of 100 have hearing impairment. This is also true with numeracy, the ability to understand and read numbers and graphs. In addition, there are emotional and mental health challenges, as well as family members who do not always agree with the patient's choices. As part of this training, we don't want to imply that overcoming barriers is easy. While we offer some solutions, we want to acknowledge that communication is one of the single hardest parts of being a clinician. Further, many of these communication challenges are also associated with suboptimal shared decision-making when studied in controlled settings. Low literacy, limited English proficiency, and low trust in physicians in particular are all independently associated with suboptimal shared decision-making. One of the most common concerns clinicians have when learning about shared decision-making is that they don't have time for it. The evidence is actually mixed on whether shared decision-making increases or decreases time. And remember, enhancing your communication skills can actually increase the time quality when you're with a patient. Remember, there is a power imbalance between the patient and clinician. Communication is essential to help us assure patients can engage. Our next communication topic area is health literacy. The pictured booklet can be downloaded from the AHRQ website listed on this slide. It is useful as a reference for what I'm about to tell you, and provides a few additional resources for communicating to patients with lower health literacy. While even seasoned readers are impacted by the demands and challenges of the healthcare system, people with limited health literacy are more likely to be hospitalized or visit the emergency room, seek treatment at later stages in illness, have difficulty complying with their treatment plan, not get recommended health screenings, or have difficulty filling out complex forms, or just simply have difficulty managing a chronic illness. Limited health literacy disproportionately affects lower socioeconomic and minority groups, and is one of the many contributors to the disparities we see across groups of people in terms of healthcare quality. There are many strategies to help patients with low health literacy. We talk about universal precautions to prevent infections and exposures. Think about these basic communication strategies as universal health literacy precautions. You can't tell by looking at a person that they have low health literacy. And even when a patient has high literacy about a particular health topic, that doesn't mean that they have high literacy in all health topics. Other aspects of this shared training talk about decision aids or tools, which can help people understand information better. However, there are many things you can do in clinic today to help people understand. For example, speak slowly and avoid jargon. And avoid things like acronyms and use words like red instead of erythematous, as they're easier to understand. Periodically check in with the patient to see if they need you to repeat or rephrase things. If you want to learn more about how to support patients of all health literacy levels, visit AHRQ.gov Health Literacy for improvement tools and strategies, training, and publications. Our next section is on health numeracy. Here I want to point you to another booklet that can be downloaded from the AHRQ website. It is useful as a reference and provides a few additional resources for communicating to patients with lower numeracy. Health numeracy is defined as the ability to use numeric information in the context of health. Studies show that even college graduates have difficulty with health numbers, and just like health literacy, low numeracy can result in poor health outcomes. Like health literacy, conveying numeric information is a two-way street, with individuals bringing their skills with numbers and the clinician offering easier to understand explanations. Numbers are prevalent in healthcare. Some examples include choosing treatments, weighing the risks and benefits, understanding that doses depend on measurement, such as weight or blood sugar, trying to follow medication instructions and take as prescribed, using measurement devices and recording and tracking results like blood glucose or peak flow meters, using multiple devices and drug types like pills, injections, inhalers, liquids, nasal sprays, eye drops, lotions, following discharge instructions. For example, take 25 milligrams of a medicine when each pill that you're given is only 5 milligrams. Comparing prescription drug coverage plans, calculating premiums, copays, and deductibles, and trying to discern percentages and proportions. Let's explore ways you can use numbers clearly and make them meaningful to your patients and their families during shared decision-making. The next few slides will offer these 5 tips that may help. First, when possible, elaborate by providing estimated numbers. Even though many people have a hard time understanding numbers, these tips can help you to communicate in a way that will help your patients to understand. Avoid the number needed to treat, or NNT format, because most people don't understand it. Also, avoid the 1 in X format because it forces people to do math in their heads when comparing values. For example, how does 1 in 16 compare to 1 in 10? Things you should do include using frequencies or percentages, keeping denominators the same, using absolute instead of relative risks, framing both positively and negatively, using pictures to communicate numbers, and making sure you know if your patient prefers metric units or standard units. I know that's a lot of do's and don'ts. We're going to go over all of these in a little bit more detail in a minute. There is also a quick reference sheet available for download on the SHARE website that can help remind you of these ideas. I also want to take some time to talk about the role of descriptive labels when talking to patients about numbers. As a hypothetical example, when talking about a medication, you might say, "This medication prevents a heart attack in 3 out of 100 patients who take it, which is a big benefit." Labels like big benefit can help patients to put numbers into perspective, but they can also introduce bias. Before you use a label, ask yourself why you're doing it. Using labels to facilitate understanding is completely consistent with the spirit of shared decision-making. But using labels to coerce a patient to make a particular choice is inconsistent with the spirit of shared decision-making. Now let's see an example. Imagine a 70-year-old man with hypertension and diabetes who has new atrial fibrillation. You calculate a CHA2DS2-VASc score of 3, giving him a 3.2% chance of stroke per year. With a blood thinner, his risk would go down to 1.1% per year. His risk of having a major bleed requiring hospitalization would be about 2% per year. Next, I'm going to use this example to illustrate the 5 recommended ways to communicate numbers. The first strategy is to use frequencies and not percentages. For example, you could say, your risk of stroke is about 3.2% a year. A better way to say this that would lead to more understanding would be to say, about 3 out of 100 people like you will have a stroke each year. When you use this kind of presentation, another important thing is to make sure your time frame is the same. You wouldn't want to talk about the benefits using a 1-year outcome and then the risks using a lifelong outcome, because then it might make the risks look worse than the benefits. Most people would likely not pick up on the nuance that you changed the time frame. The next strategy is to keep the denominators the same. There is also research that using phrases like 1 out of 33 have a stroke or 1 out of 50 have bleeding will lead to misunderstanding. There are some studies that people will conclude that 1 out of 50 is actually greater than the 1 out of 33 because 50 is a bigger number. A better way to say this is to make sure your denominators are the same. For example, about 3 out of 100 have a stroke and about 2 out of 100 have significant bleeding each year. The third example is to use absolute risks instead of relative risks. There's a large body of research that people misunderstand relative risks as they tend to overestimate the benefits or risks of a therapy. This slide shows some examples. A poor way to communicate this would be to say there is a 300% increased risk of stroke without a blood thinner. The problem here is that you're using a relative risk of 300%, and people don't know if that is a 1 to 3% increase or a 10 to 30% increase. The same problem is true if you use language like that in the second bullet, saying your risk of stroke is tripled without a blood thinner. While both are technically true, this type of presentation will lead to misunderstandings. A better way to say this would be to say your risk of stroke is 3 out of 100 without a blood thinner and 1 out of 100 with a blood thinner. The fourth strategy is one that is based on a lot of psychology research. This strategy asks you to frame things both positively and negatively. If you just use the negative framing, then people may focus on that negative outcome and not recognize that there's a positive. Another way to say this would be to say something like, with this medicine, 2 out of 100 will have serious bleeding. This also means that 98 out of 100 will not have bleeding. As you can see, the way that is said doesn't just focus on the bleeding side effect, but also focuses on the fact that most people actually do not have serious bleeding. This type of framing is most important for people with low numeracy because they may not automatically translate the numbers in this way. Finally, if you have the resources or if you have a tool like a decision aid, then sometimes you'll have statistics presented like this in a picture. There is a body of research that people who see pictures like this are more likely to answer knowledge questions correctly. If you look at this picture on the left, it says that without treatment, 3 out of 100 people like you will have a stroke each year. Then on the right, it says with treatment, about 1 out of 100 people like you will have a stroke each year. This is the same data we've been talking about in all the other slides, but when presented like this in a picture, research suggests it leads to better understanding. While this format is not always available or possible, it is still a principle that you can consider when communicating with patients. So in review, numbers in healthcare can be difficult to convey. Remember, even college-educated people have difficulty with health numbers. It's also important to note that numbers are a very cognitive thing and are also not all that helpful when a patient is in a highly emotional state, such as right after receiving a difficult diagnosis. Like many things, conveying numeric information is a skill that takes practice, and it does get easier over time. Let's move on to the teach-back technique. On the slide is a website where you can access some of AHRQ's resources, including information on the teach-back technique. One of the best ways to learn the teach-back technique is actually to watch it in action. Before we get into the details, let's watch a short video of a clinician using the teach-back technique. Now that we've watched the video, let's talk a little bit more about what teach-back is. Teach-back is a technique in which your patients can use their own words to explain what they need to know about their health and what to do to get better. Teach-back can help you make sure you are conveying information in a way that your patients can understand. As your patients teach back what they have learned during the visit, you can be assured that you have effectively communicated with them. The good news is that teach-back can be done in as little as 1 to 2 minutes. In many ways, the teach-back method is one of the most important health literacy strategies. If you just ask, did you understand, you'll never know whether they understood or not. So to do the teach-back technique, you take the information you want to convey and you chunk it and teach it to the patient. And then you ask them to explain in their own words what they understood. If they teach it back correctly, then you can move on. If they don't teach it back correctly, then you need to reteach using different words. What to say while using teach-back during shared decision-making. Explain things clearly using plain language and avoid using medical jargon and vague terms. Make sure your patients know your goal is to check how well you explain the health information, not test their knowledge. Teach-back takes skill. You don't want your question to feel like a quiz or feel condescending. Language is important. Find and practice words that are comfortable to you. For example, we talked about 2 treatment options today, watchful waiting and starting radiation in a few weeks. I want to make sure I've explained each option clearly. Would you please tell me how you would explain watchful waiting to your family? Teach-back is just another tool to improve communication. It may not always be possible in a busy setting. However, when you're helping a patient make a big decision, it can fit nicely. When considering the SHARE approach, it could be used in the H, where you help patients understand their options, and with the A, where you assess their values and preferences. Thus far, we've talked about communication barriers, health literacy, health numbers, and teach back in this communication module. The next area we are going to address is cultural competence. On the slide is a web address linking to AHRQ's materials on cultural competency if you would like to go deeper into the topic. Culturally competent care is a very broad topic. A full discussion of culturally competent care is beyond the scope of this shared decision-making training. At the same time, we would be remiss to not at least mention its importance to shared decision-making. Culturally competent care is also key to understand your patient's cultural perspective and background. Cultural factors influence patients' health beliefs, behaviors, and responses to the medical issues. Even within groups, it is important to recognize that individuals can be very diverse in their preferences. Be aware of your own culture and how that may affect how you communicate with your patients. It's important to be aware of disparities in communication. People of color often experience less trust and less relationship building with their clinicians. Patients with multiple minority identities, such as sexual orientation and race ethnicity, are at particular risk for poor communication. Provide qualified medical interpreters for patients whose English proficiency is limited. This is actually required by the Civil Rights Act and the Americans with Disabilities Act. A couple quick points on interpreters. Provide qualified medical interpreters for patients whose English proficiency is limited. If possible, avoid using family members, and especially avoid using children. The final area that I want to discuss is working to build trust. Trust is a recurrent theme in many of the qualitative studies asking patients how they want to feel about their medical care. Bullet 1 reminds you to encourage your patients to ask questions. You might probe with, "What questions do you have for me today?" Recognize that in many cultures, family members are deeply involved in health decisions. Try to involve extended family members when planning care. Finally, create a welcoming environment. You can even put a welcome sign in a variety of languages on the office door. Place a few magazines or other print materials in the patient's native languages in the waiting area. This will show a caring attitude. Learn how to interact with diverse patients. One of the most important things is to just be interested in your patients as individuals and in their unique cultural perspectives. Invite your patients to explain what is important to them and how getting and staying well works in their community. Consider hiring a cultural broker or having a patient advisory panel if your clinical setting is enriched with a specific cultural group. You can find more on cultural competency at the website listed on the slide. Key takeaways on communication. Patient communication is challenging, but clear health communication is key to effective shared decision-making. Use universal health literacy precautions during shared decision-making with all your patients because you can't tell by looking who has limited health literacy. Follow the strategies for making numbers easier to understand when conveying benefits and risks and treatment options. Even college graduates struggle with health numbers. Key takeaways: communication. Use TeachBack to make sure you convey your health message in a way your patients can understand as you engage in shared decision-making. Ask your patients about their health beliefs and cultural norms to build relationships based on trust during shared decision-making. Thank you for watching this video. Hopefully you found it informative and you picked up a couple tips that you can take back to your care of patients.